Good evening, everyone. So we'll jump straight into the case. So it's a 49-year-old female, a native of Kottayam, working in Israel as a staff nurse for the past 2.5 years. She's a known case of diabetes mellitus on oral hypoglycemic agents. So what we got initially was this document in Hebrew.
This is the discharge summary she brought from Israel. It is written in Hebrew.
And of course, we couldn't make...
But she made a correct thing.
So we used Google Translate to translate.
Google's translator was used to get the English version of this. This is a translated manuscript. Yes.
So to summarize the document that she had brought, she was apparently normal till February 2025. She was admitted to a medical center in Israel on 11th March. She had fever of approximately 38.5 degrees centigrade for like 2 weeks on and off. She also had progressive dyspnea, chest heaviness, generalized fatigue, bilateral pedal edema. And on going to the hospital, she was extremely dyspneic. They straight away took her for a CT thorax. They found a large pericardial effusion, and the echo confirmed the large effusion. And consequently, a pericardiocentesis was done over there.
These all things from the discharge summary produced by her.
Apparently, 700 ml of serous fluid was aspirated, which was exudative in nature. One of the cultures grew staph epidermidis, but they have ruled it out as a contaminant. ADA was not elevated. No malignant cells were found. And the other investigations done over there showed a raised total count, a raised CRP, raised ESR, and a negative troponin. Among the other investigations, her NT-proBNP was mildly elevated. Then they had given a pulmonology consultation for the patient because they were initially suspecting TB because it was an exudative effusion and she was from India. That was their first DD. TB was, they did a TrueNat, they did an ADA, an IGRA was done. Everything was found to be negative. They then referred the case to a consultant rheumatologist who did a complete ANA, ANCA workup, which were all found to be negative. Then they referred the patient to the infectious disease department, who sent an entire panel of viral markers and bacterial cultures were sent. But none of the workup came out to be positive. So they empirically treated the patient on penicillin, switched to colchicine, 0.5 mg BD. Then diuretics were given for volume overload. And as the patient improved, they discharged her. The provincial diagnosis was acute idiopathic pericarditis with a large effusion. So she was given air travel clearance because she was found to not have any. She didn't have any active infections according to them, and she came back to Kerala.
This is the clearance for air travel. So are you happy with the diagnosis or any other suggestions, any other alternative diagnosis?
Basically a case of PUO in a healthcare worker working in the Middle East.
Yes.
And we have to think of infections first. And then being a lady, other causes which we already, in the other case, we were talking about connective tissue disorders and others. Then, of course, HIV and all those things you might have done already.
Nice.
Yeah.
So
PUO from the Middle East.
Yes,
so you're very good in using the AI and Chat GPT and all.
She was discharged in an ephemeral state with a totally almost normal heart. Pericardial synthesis were performed twice there. Then all her parameters were almost normal limits as per the records. That is why they permitted her to travel. And she was ephemeral for 15 days. Then only she was discharged from the hospital there. And the patient came to our emergency department even after reaching Kerala and after nearly 2 weeks' time.
One more point is working in Israel sometimes can be a red herring. So we have to take it as an infection in a healthcare worker, whether it's Israel or Cochin. Israel, if we get too much oriented to that, we may miss common things like tuberculosis and other things.
Interested in a history. That history is probably I'd like to have. How long was the fever?
2 weeks, sir.
Did she have any joint pains?
No, she didn't have any significant joint. Just back pain she had, but she had been having it for quite some time. But other than
She
that,
was having generalized edema with the pericardial.
Generalized any history of contact
That is
with
why
pets? Pets?
no contacts with the pets.
No contact. No high fever. or anything.
She was staying in the hostel. So
No high fever,
chance.
no history of high fever.
She was staying in the 4th floor of the hospital. Not going out because of the various reasons. They are not permitted to go out. Illa, sir. No much weight loss. Because she was edematous. That is the reason why there is no significant. Yeah, for 15 days it was there.
yes.
It was continuous fever.
Continuous.
Chest X-ray did not show anything else for tuberculosis lesion.
No tuberculosis lesion. And Dr. Paramesh and Dr. Thomas Curry, they
Possibilities.
Yeah.
One is a viral pericarditis,
very good. Viral pericarditis.
or even an acute tuberculosis pericarditis also is a possibility, as he rightly said, in a healthcare worker.
But the tuberculosis, they have done almost all investigations, but there is no positivity. They have written very clearly, no, we ruled out tuberculosis, autoimmune disease, infectious diseases, and finally they made a diagnosis of idiopathic pericardial effusion.
Have they
Just for the academic,
have they ruled out brucellosis? Because from Middle East, routinely we get atypical presentation.
Yeah.
They have ruled out.
yeah, just for academic sake, for the residents, if there was no other involvement like pericardial in a nurse, we have seen rarely the cases of factitious fever. But this is not that.
Fever was there. Malignancy, they suspected and they told us to rule out after reaching in Kerala. Sir. Yeah, that is true. Very good. Lymphoma is the strongest possibility in this patient. Lymphoma, very good. Lymphoma. Then another possibility is fungal infections, which is also very common in Israel area. Fungal histoplasmosis and coccidiomycosis, both are very common. This we found out by searching. Okay, proceed.
So she presented to her ED. Shortly after return from Israel, she had again developed dyspnea, chest discomfort, bilateral lower limb edema. She was initially taken to a local hospital, then referred to our center. We received the patient in ED and we went through the above mentioned documents. And on examination, she was found to have bibasal crepitations. Her S1 and S2 were barely audible. She was her BP was on the lower side. She was found to have tachycardia. She was tachypneic. Her saturation was low under room air. Her JVP was found to be elevated. So we immediately alerted the cardiology team. We did a bedside echo for her. She was found to have pericardial effusion in the echo.
These findings are very, very important. She picked up, I like to congratulate in front of all of you. She picked up these findings. JVP is raised, bilateral pericardial edema, heart sounds are very barely audible. And immediately, instead of even taking an X-ray chest, she brought the echocardiogram and did an echo. She knows only a few things, but she told us, sir, the patient is having massive pericardial effusion. So we immediately called Dr. Joe to the casualty. He is the person who is available all the time in the hospital and he will always respond to our call. He came immediately. Jabir was also there. They immediately took the patient.
They did a pericardiocentesis. Then patient's symptoms subsided significantly after the procedure and she was admitted under us for further evaluation. Next day was pretty uneventful. However, a day later, she again became dyspneic and another pericardiocentesis was performed.
So twice pericardial synthesis were performed by them.
And fluid was found to be exudative, cultures were sterile, ADA was negative. The picture was pretty much similar to what they had found in Israel. Now, after the tapping was done, we did a chest X-ray, which showed cardiomegaly. There was pulmonary plethora.
Then listen to the findings.
And there was dilated middle and right pulmonary arteries. There was peripheral arterial pruning present. We even suspected some level of COPD because patient had on and off dyspnea.
Yes.
Consequently, an echo was done for the patient, which revealed moderate to severe tricuspid regurgitation, moderate to severe pulmonary artery hypertension, among other findings. Now, we were
See, with these findings, can we explain all the problems of the patient? Or what all things is remaining unexplained?
Rapidly accumulating pericardial effusion.
One thing, rapidly accumulating pericardial effusion, agreed.
A little unlikely to be tuberculous.
Yeah, unlikely to be tuberculosis, agreed. 1. 2. This patient is having
Exudative fluid.
exudative fluid. Second thing. Third, uneven. See the findings. He is having JVP raised, but he is having features of pulmonary artery hypertension, even after tapping the fluid.
Whether a lateral view was taken or a chest CT was done.
Yeah, we'll come to it later. Okay, so this is the picture. So we want an answer for why there is mitral regurgitation, why there is right atrial enlargement, why there is evidence of severe pulmonary artery hypertension are the things we want an answer to it. There is no other valvular lesion or nothing in this. We were satisfied with this. We explained everything. After discussion with the pulmonologist, COPD is there. Core pulmonale, we can explain all these findings. So we were very comfortable with this. But the cardiologists were not agree.
Pericardial effusion.
Pericardial effusion is coming very frequently. And these findings, they want more explanation. And this patient was diagnosed in the emergency department. And there itself, we did the pericardial synthesis because the patient was in cardiac tamponade. Luckily survived. Okay. This is the picture. So cardiologist.
The cardiologist insisted on doing a transesophageal echogram because we wanted to look further into evaluate the etiology. So we went ahead with it, and the patient was found to have a higher ostium secundum ASD with a left to right shunt.
Large ASD was there. It was unnoticed in the echo done in.
But still doesn't explain the full clinical picture.
No.
Yeah. Still, this will not explain the pericardial effusion, I agree. But the cardiac finding which we have seen, we can explain. The enlarged right atrium, enlarged right ventricle, then pulmonary artery hypertension.
Transesophageal was probably thought of to roll out vegetations.
Yeah.
But then they found something else.
They were telling something, AST they want to roll out. Okay. So, yeah, markedly enlarged. Yeah, that is the point. The right atrium is enlarged very much. So they told it is because of something coming from that area. So they want to roll out AST. That is why they did a TE, transesophageal echo. That is the diagnostic test for AST.
It's a little surprising that she got a clearance to go and work in Israel.
Yeah.
That we will come to it later. Okay, then. Echo will be normal. Routine echo done by, now echoes are done by all technicians. They won't be able to find out such things. Okay, proceed.
Meanwhile, the next day, the patient developed complaints of chest pain. She was found to be restless. ECG showed T inversions in lateral leads. The trop T was found to be elevated. And on echo, there was no pericardial effusion on echo. And consequently, the patient was taken for a CAG. So this was the ECG. It had some T inversions on the lateral leads.
One early morning, patient suddenly developed severe excruciating chest pain. Severe chest pain. And it was not responding. We thought it is because of pleurisy and other things, but ECG showed a minimal change, but the pain was so horrible. But TROP-I was positive. So we again called the help of a cardiologist.
Dissection?
So, no,
Aortic dissection?
no,
No.
Okay. Okay.
Dr. Sunil is here. Dr. Sunil. Sorry. Yeah, sir, tell me. Yeah.
Pericardial effusion.
It's after tapping,
no,
sir.
that was after tapping.
After 2 tappings, we took this.
Usually you see a stenciled out.
Yeah. But it was taken. We have got not time actually to take an X-ray.
ECG also was not quite suggestive in the sense, voltages were quite normal.
But the T inversions are there in the anterolateral lead. And deposit.
The fluid analysis, pericardial
Sir,
fluid
exudative fluid.
only.
Sorry,
Okay.
nothing in the cultures was sterile. And ADA was negative.
ADA were negative, and we sent malignant cells, it was negative. Then TrueNat negative, AFP negative, ADA negative. So no positive findings we got from the pericardial effusion.
Then the CAG suggested a double vessel disease. And
Because of TROP-I positivity and severe pain, they made a diagnosis of acute coronary syndrome and took the patient for a primary angioplasty.
And a drug-eluting stent was placed in the LAD.
It was at near total occlusion, and they put stenting also.
They can dare that in Lissy. No, I don't think many would do that with massive pericardial effusion. Anyway, she survived that from Israel, no?
Then CECT was done, and it showed multiple small to minimally enlarged prevascular, right lower paratracheal, pretracheal, para-aortic, right hilar, and subcarinal lymph nodes, largest measuring 15 millimeters. So this was the CT report.
This is the CT report. Somebody was asking for the CT report. This is the CT report. Yes, with the CT report, anything else or any comments you want to make? Lymphoma, yes, lymphoma. We also thought it can be lymphoma. Sarcoidosis. Our pulmonary department people also was in that same opinion. Sarcoidosis may be a possibility. Yes, then.
So generalized lymphadenopathy, mediastinal lymphadenopathy with exudative pericarditis. That boils down to that.
Yeah. Toxoplasmosis. That is a possibility where you will get this type of picture, multiple lymph nodes, fever, effusion, everything we can get in toxoplasma. Okay. But I think we have done that test. Okay, proceed.
So some of the initial labs that we had done showed elevated CRP, elevated NT-proBNP. Then we did a comprehensive fever panel also. With a viral panel, BioFire was sent.
We thought it is a viral pericarditis because of the frequent large effusion. It was coming.
Did you get a gynec evaluation done?
No, not.
Always, please.
So the panel, we sent the viral panel, which is known as the BioFire. That came to be negative. CMV, HIV, adenovirus, COVID, EBV, everything. Then toxoplasma, yes, your toxoplasma is negative. Then fluid for AFP, ADA, TrueNat, everything is negative. IGRA is negative. Even Mando is negative. Then scrub typhus, wheel felix, all came out to be negative. Okay.
And for a rheumatological evaluation, we had done ANA, IF, P-ANCA, C-ANCA. They were all found to be negative. And the ACE levels were also found to be within normal limits.
That is for sarcoidosis. This is for undergraduates. PG students. ACE levels, we are doing it for rolling out sarcoidosis. Okay.
One thing. Did you consider a pericardial biopsy?
Not done in this
No,
point
it
of
was
time,
not
sir.
needed.
Not
Because in
considered.
that
It is,
CT report you mentioned there was diffuse pericardial thickening.
yeah, pericardial thickening was there. So it is a long-standing effusion. Cardiologists of the opinion that any type of chronic pericardial effusion will produce thickening of the pericardium. It is a non-specific finding. We can wait. That is what they are telling. Okay.
Now, the next day, 2 days went by uneventful, and then the next day evening, she developed redness, bilateral eyes, and blurring of vision during a hospital stay.
Yeah.
It was more prominent on the right side, more on the left compared to the left. Then an ophthalmology consultation was done. A comprehensive eye examination revealed patient had developed features of iridocyclitis. There were keratic precipitates and cells and flare in the anterior chamber. There were multifocal choroidal lesions, yellowish white patches suggestive of choroiditis. There was optic disc hyperemia and vascular tortuosity was also noted. This is the
picture. So after these incidents, pericardisynthesis, patient improved well, we are happy. Patient developed cardiac failure and pro-BNP was very high. With the last 6 diuretics, that was improved. Then patient developed, one day patient again developed acute myocardial infarction. Stenting were done. Then another day evening patient was telling, I am not able to see anything. So that is the picture. This is the picture. We are also in darkness, to be very frank.
An OCT was done to rule out retinal detachment.
Yeah, it is a multi-system involvement. Correctly said. So what is the possibility? What are the things we missed? Sir, autoimmune. ANA is negative.
Yeah.
Cianga, Pianga, then Apla, everything is negative. Yeah, tuberculosis, everything will be negative, but still patient may have tuberculosis. The only problem is this is the era of
Investigation.
Litigation, medical negligence. We are not supposed to start ATT without this. There are 5 cases pending in the High Court. They call me for expert opinion. That is what I am telling. Don't start ATT without a proper evidence. Without a proper evidence, either by blood investigation, sputum investigation, or a biopsy. We are not permitted because ATT will produce some complications. That is the problem. I will tell you it later. Okay, then.
Did she suffer from COVID anytime?
No COVID.
So post-COVID?
No. Next, please. Proceed.
So the new clinical signs that had presented just then prompted us to probe deeper into the history, running through her life and routines back in Israel, and brought our attention to a key detail, which was a significant step towards the diagnosis.
Yes. Yeah. She, from questioning her, she was not in the habit of taking tea or coffee from here. That conversation finally led to a very important thing.
Brucella.
Proceed.
So, patient had a history of mixing raw milk before losing directly from the dairy farm with her morning tea.
See, അവിടെ ഈ പാല് കറന്നെടുത്തിട്ട് അതിന് ചൂട് പോണതിന് മുമ്പ് അതിനകത്തേക്ക് ചായ ചൂടാക്കി ഒഴിച്ചിട്ടാണ് കുടിക്കുക. They are not boiling milk. They are not pasteurizing milk. So this gives us a clue to where to turn. So immediately we send an investigation. It is just like Mohanlal in Spadigam. You are remembering Adu Thoma. ആടിനെ കൊന്ന് ചൂടാറുന്നതിന് മുമ്പ് രക്തം കുടിക്കുന്ന ഒരു സീൻ ഉണ്ട് അതിനകത്ത്. Remember, I think Spadigam film everybody has seen. Okay. അതുപോലെ ചൂട് പാൽ ഇവിടെ കുടിച്ചുകൊണ്ടിരിക്കുന്നു എല്ലാവരും. Not only her, everybody is doing the same practice there. Next investigation.
So her brucella IgM was found to be positive.
This is what I told initially. So many cases we have come there. Brucellosis come typically Middle East.
Brucella will explain all the findings. The pericardial effusion, the cardiac failure,
Eye involvement.
Eye involvement is very typical. but we are not used with the eye findings. So we didn't thought of a brucella at that point of time.
So her IgM brucella was found to be positive, and she was started on injection streptomycin 1 gram OD for 2 weeks, which was and oral doxycycline 100 mg BD and trimethoprim sulfamethoxazole double strength tablet BD, which were continued for the next 12 weeks, considering her pericardial involvement. Topical steroids were given for her iridocyclitis. Patient was also continued on antiplatelets for her CAD. Colchicine was continued for a month, and tab sildenafil was added in view of severe PAH. And diabetic medications were optimized. On follow-up, patient was found to be much better. Her eye findings improved over 1 month. And she has gone back to Israel now.
She went though, yeah, but guideline says brucella IgM estimation is enough to make a diagnosis if the clinical features are present. Even brucella PCR is also not available in our place. What we can do is brucella IgM. That is the test of choice in our place to make a confirmation of brucellosis. Brucella will explain everything.
Even explains the back pain.
No, she didn't have any typical joint pains. It was a typical
Back pain
It was a
is
typical
there.
presentation.